announcements we've been trying to work on to address IQR, and giving an update on some of our work on digital inequity, looking forward into utility and security in the spring. Next slide. Again, the custom is the custom. Thanks for joining. Due to the large number of attendees, we mute you upon entry. We ask that you remain muted to avoid background noise. All calls are recorded and available on the Confluence. You're encouraged to actively participate. I do try to make sure that I'm watching everything on the chat. Hi, Jonathan. If you're new to the call, or even just for the sake of other people on the call, if you can put your name and the organization you are from in the call in the chat log, that would be appreciated. Please send all chats to everybody just so that we can make sure that everyone's staying part of the conversation. Next slide. This is our common antitrust practices slide. So Gravity Project participants have the responsibility to comply fully with federal and state antitrust laws. And then the other three bullets, so individual speaking or providing written comments shall refrain from any discussion which may provide the basis for an inference they've agreed to take any action related to prices, services, production, allocation of markets, or any other matter having a market effect. They don't discuss pricing, and we just want to make sure that these are the guidelines of participating in the call. Next slide. Hi, Tammy. A big thank you to our 2023 project sponsors for the Gravity Project. We would not be able to do what we do without them. Also, great thanks to our in-kind partners, AMA, Civitas, and Networks for Health, notably. Next slide. This is the agenda today. We're going to go through some brief announcements, review the project schedule, run through the updates to the utility and security value sets that we're collating to assist implementers with IQR, update you on the interpersonal safety process again, this IQR aligned, and then have a conversation on IC10CM and updates when we started to have discussions on submitting for the December deadline. Just thinking about the intersection of the domains we're submitting on digital inequity, digital access, digital literacy, an upcoming utility and security build in the spring, and we have some thoughts to work through with you. Next slide. Next slide. Very brief announcements. We are looking forward to the online virtual January Connect-a-thon. We're hoping to leverage many of the testing partners and pilot friends we have from our pilot work stream in that work. If you are not able to attend because of cost, we're trying to figure out if we can get some funds to support you in attendance. We definitely want our CBO friends there. There is a focus, more to come on that. Again, Lantana, the team that's coming to us in the tech team, supported by CMS Obrey, is looking forward to that Connect-a-thon. There's a lot of planning going on in our meetings, so you'll hear about that at the Wednesday 1 to 2 tech call for Gravity. We finished our social care co-design work, really looking at the conceptual model and exploratory use cases that are critical to advance social care. The report on that will be published in December, and there'll be a public webinar on our findings, again, thanks to completion of that, with from our friends at Civitas and RWJ. Next slide. Next slide. This is our roadmap. So here we are in the fall, where we had our little kickoff for the Coding for Food HICPIC work. We are submitting grants for that work to be able to start build in 2024. We're working on the IQR hustle here in the fall as well. And then down below, you can see the technical work stream. Really are trying to we're prioritizing new work and new use cases and elements and projects in the technical work stream in our internal meetings. And again, voicing that in the technical call from 1 to 2 Eastern Standard Time on Wednesdays. And then we're also wrapping up our pilots for this calendar year. Our last pilot formal meeting is next month. We'll be hearing from Pima County. And then also hearing from member implementers from National Association of Community Health Centers. And again, that report's coming out regarding social care co-design. Next slide. And then 2024. This is slim. There's probably more that will be added to it over the course of the next months. But we're looking ahead into a full build for utility and security. Again, right now, all we're doing is leveraging existing terms into validated value sets to support implementation for IQR. We're going to be building those expanded transportation insecurity IC10CM codes based on implementer feedback, and hopefully starting build on those HCPC terms for the first set of the Coding for Food initiative. And then likely adding and braiding other elements onto that, but that's what we have for now. Next slide. Any questions regarding the plan? Okie doke. Next slide. Again, this is unique for us, and it's very kind of custom, like makes sense for where we are. So as we develop out our domains, not all of our work is necessarily new domains. Sometimes it's packaging information to support implementers and members. The inpatient quality reporting coming into reporting in January is a huge push. So what we're really working on is leveraging terminology that we have toward supporting IQR use cases. No new terminology right now, and just kind of grouping it in intelligent value sets to support implementation. Next slide. So this is the adaptation of our customary terminology development life cycle. We are really just reviewing existing terminology. We will not be building anything except for value sets. We are not analyzing gaps except to position ourselves well for spring build. We're going to go into the utility and security build smarter than we ever are, because we will have just thought deeply about things that need to be there and aren't there. And then we'll close out in December for a holiday break with those value sets ready to go into VSAC. Next slide. Here we are. So again, we only have this session and then the next session for review. Again, review is not like what we usually do. We're not suggesting any new terms. And then we'll have our vote at the end of November so that we can take a holiday. And then your job is to just review the master as it gets published on the Confluence and make sure that it seems fit. We've already gotten some really great comments on definition updates, and we're really grateful for your engaged collaboration on our work. And again, this is the first meeting that shifted in order to not overrun the HL7 vocab workgroup, which is a critical sister work group at HL7, and we needed to make sure that we allowed members to go between both. And thank you for adapting your schedules. Next slide. All right, so this is the setting for why we are here. Again, usually we start new build in August and run a full cycle of build until December. Because of the delay in kicking off with digital access and digital literacy, that whole cadence got shifted. And so we had an opportunity. Absolutely, we can. Yeah, we can put it in it'll be coming into the Confluence very, very shortly. I mean, into the chat very shortly. Every link we mention will come into the chat, Rob. So the context is the inpatient quality reporting, inpatient prospective payment, screening for social drivers of health, and screening positive for social drivers of health measure enter reporting in January. We really had an opportunity to lean in to ensure our value sets and guidance met implementer needs, because we didn't have specific value sets for utility and security, and we knew full well that we were going to be addressing utility and security in the spring anyway. So it made sense to leverage our subject matter experts and our existing terminology to lean into that domain. Again, the social drivers of health measure covers food insecurity, housing instability, all the subtypes, transportation needs, utility difficulties, and interpersonal safety. We'll be talking about both utility difficulties and interpersonal safety today. Next slide. Thank you, Sarah B. It's there in the chat now, Rob. So the approach is that we are building our utility and security value sets really from previous domains of financial insecurity and material hardship. And then we're crafting guidance for aligning interpersonal safety screening with the evidence, which is also going to create some opportunity for new domains in the future in order to have a robust recommendation. Next slide. Next slide. All right, so this is now moved because it's not over the next months. We're finishing our work. Again, full utility and security new terminology build is in the spring. Utility and security value sets are based off financial insecurity and material hardship. And we just wanted to clarify for everybody past decisions that have come about. And again, I'm sorry, I repeat this every time. It's just really important. When we did inadequate housing and material hardship and financial insecurity concurrently in 2021, led by the U.S. Housing and Urban Development, Department of Housing and Urban Development, and material hardship and financial insecurity experts. There was a very clear line in the sand that functioning equipment and plumbing, like a working stove, sorts into inadequate housing, where connectivity to utilities sorts in at the time to financial insecurity and material hardship. So you'll see in the instruments that we've collated, that we reviewed last time, and we'll briefly touch upon them again, and the diagnoses and interventions that we're collating, that anything regarding inadequate housing or actual equipment is not in the set because of that precedent of that work. Again, we're not creating new precedent until we have the full terminology build in the spring. Next slide. This is just a grounder, a reminder that part of the complexity of building the utility and security value set now is that the concepts are split across two different types of things, right? So when we did it before, there's the worry or having difficulty of paying, that's in financial insecurity, and then there's the I don't have it, that's in material hardship. So we have to pull them together right now to have utility and security codes. There's lots of utility elements in there, as you already know. Next slide. And again, this is just the spectrum of financially driven insecurities, that spectrum of worry to quality and safety, and then cultural acceptability when it applies. And we're really looking in utility and security to worry, stability, quantity, precedence, and quality and safety. Next slide. So we just, and this is the looking forward again, really the biggest area of development we have to address in the spring when we have our full team on board is the difficulty paying, because most of the concepts with not having it because it's actually turned off and gone were part of material hardship. So we look forward to filling those gaps right now and recognize that they are, how does it, that we're not able to support them right now. So how does our timeline meet need for hospitals starting S3 screening in January? Because we will have value sets to support them in December. So if they're trying to implement IQR regarding utility insecurity and interpersonal violence, interpersonal safety, they can at least stay within the guardrails of gravity terminology and social determinants of health, USCDI aligned elements as they do the screening. And of note, the current IQR measure doesn't have a recommended data standard that it references. It doesn't even have necessarily recommended instruments. It's just that our implementers are so advanced that they don't want to implement without being aligned with standards. So we're doing this to assist them. IQR does not require capture of the terminology. No, it's an attestation. It's like there's a couple of HCPCS codes that are being utilized. There are no actual discrete LOINC codes or SNOMED-CT codes required for reporting, but we do note, and again, I can say this very humbly because I am the lead of the revision of the IQR measure, that CMS is changing that in upcoming versions of the measure and fully aligning with gravity terminology in future years. So that is the plan. So right now, you just have to screen, and it's the screen rate positive, and you can use any instrument, but that breadth and possibility is going to be narrowing very shortly. So again, our member implementers and our friends in the ecosystem want to align early and align now. And so if by giving them this guidance, they'll be really well positioned to do so. Next slide. Any other questions on IQR? Okay. One thing we note again, and I'm just saying this again, it's helpful to repeat it. The CDC submitted an IC10-CM code called Inadequate Housing Utilities, looking forward to IQR reporting, really based off the Accountable Health Community's health-related social needs instrument. It is a little bit challenging because we separated inadequate housing from utility insecurity with HUD. So we have this term now that is in the ecosystem that we have to figure out what to do with. And then we also know that even semantically in its meaning, it's only ever going to represent likely the full worst scenario of utility insecurity, because housing wouldn't be inadequate if you're just worrying about not having your utilities shut off, or you've been threatened to have it cut off. So there's a lot of good thought we're going to have to do for the spring, but right now, for the purposes of this value set curation, Z59.12 and other codes that can be utilized will be part of the value sets. Next slide. Okay, and these are our SMEs. Next slide. Okay, new content ever so soon. All right, next slide. So these are the current, so last time we were here, we addressed screening instruments. We're going to touch on them very, very shortly again. But these are the existing gravity-developed terminologies that associate with the domain of utility and security that we have pulled in for your review for an early value set to support implementation in December. Some of these terms are so perfect and good that they will always likely remain in utility and security value set. Some of them are so non-specific that they might evolve out of the value set after our full build in the spring. But in order to represent the breadth of the domain, again, that worry to not having, and in order to align with all of the screening questions that you've all looked at and approved last time, these are our base diagnoses that we have so far. Again, all of these will be on the master, posted for your review by Friday afternoon, end of day tomorrow. And you can see here that financial insecurity code is holding space for the worry about having your utilities shut off because we don't have a different code that can represent that concept. And if we didn't include it, the inadequate housing utilities code would not be a match for some of the findings from the screening instruments that you have. So we are just offering both. Any questions? My cat's being very persistent. All right. Any other questions? No, we're good. My very fluffy cat. Okay, next slide. We do have really quite good goal statements that, again, were part of utility and part of material hardship and financial insecurity. So this is able to afford heating, able to afford cooling, able to afford electricity. Again, you have those core 3 elements that we know are part of AHC. The only thing we're missing is water, and we're working on that. And then you have a meta and able to afford utilities in residence, right? So those are really existent and applicable goal statements that we can imagine staying in the value set as we work for utility and security fully in the spring. Any questions here?
Sarah?
Hi. Yes.
Hi. I would just comment about these goal statements that they may become more and more significant for patients and perhaps geographies where they weren't an issue before. We're having a major discussion, I will say politely, in California about proposed revisions to utility rate setting.
Oh, yeah.
Which there seems to be quite a lot of disagreement about who's going to benefit and who isn't. So I'm glad to see all of this in the goal statements and just wanted to comment that these may become more significant for more people than traditionally.
Thank you, Lucy, for your thoughtful comments as always. Any other comments on the goal terms? My cat. All right. Next slide. All right. So these now we presented to you the diagnoses. We presented to you the goal statements, and we're going to run through some updates to programs, professions, and roles. Right. So one is the addition of lifeline communication program, because even though it does cover internet and we, therefore it would be in digital inequity and digital access, it also addresses phone, which for right now is hovering, trying to figure out where it settles. Again, some people define utility and security as including phone access. Some people do not. I don't mean people, I don't mean the SMEs. I mean like some instruments, some approaches, some regulations. So for right now, we're leaving all phone elements in the utility bucket for now. So lifeline communication program is there. Next slide. These are, again, the common assessor professions that we always have. Next slide. And all of these will get wrapped in with our syntax, right? So refer to, education about. And then, so these, again, the continuation of those constant roles that are across most domains. Next slide. Next slide. And this is the update on the the high level view of the screening instruments. We reviewed them last time. There's one new instrument. We neglected to include the VA Acorn screening tool. So we are adding that back at the time, and you can see this on the master. And there's a couple that have been removed, and I will explain why. I had the opportunity as the director of terminology to use the brilliant resource the terminology team made, and they had created that table, which was the first table of its kind detailing all of the face validated gravity accepted screening instruments. We can drop it into the chat. Really, again, the significant thing that it hadn't been in the ecosystem until we did it, because the last survey we had of all the instruments in the ecosystem was in 2019. And according to that, and according to our data, your current life survey situation, which used to be a KP tool, is no longer in publication by KP. We know this because we tried to submit it to registry for inclusion in LOINC. And we know that, therefore, if it's no longer being utilized, it doesn't make sense to include it, even if it once had a question that was utility and security. So we are removing it. And I only did this by using the amazing instrument, the table we made. The other one that's being removed, and does that make sense? Like, if we can't actually use the tool in practice, it does not make sense. Correct. Yeah, so there's no, so Sarah Bahal has dropped the amazing table. And then Rob, correct. We don't make any instruments ourselves. All we do is assess the existing instruments as whether or not they're face valid for the domain with the assistance of subject matter experts. And then we worked with registry to encode any gold standard or nationally recognized or disseminated instruments, like all federal instruments, like even the American Community Survey from the US Census Bureau. So we just collate things that are in the ecosystem already standardized. The reason why the Cowlitz one was removed is it's actually, you can't find it. So we can't point people to it. It was submitted once very, very early in food insecurity, and so it doesn't make sense to keep it on our instrument list because nobody can find it to use. Rob, do you want to come off mute so you can help me understand your question? Hi.
Sure. Hey.
Welcome.
Well, sorry to be interrupting you, but this
is the way.
actually,
Everyone's really quiet today, so that's not normal. Please talk.
Yeah. So I've been trying to understand where you guys are. So this has been really helpful. The value sets that you just went through were, they represent the sort of things that you might call an observation or a question, right? Like, you might have this, and so you're trying to determine whether they say yes or no in some way. And then there's the goals you called the goals, which are really, the intended kind of outcome of that that assessment. So now you're identifying screening instruments that fall into the areas that the domains. You've got these set of codes that you want to be used as, let's say, exchange, for exchange in terms of like identifying these, utility risks and things like that. So that's why I was asking that question, because these tools have outcomes that may or may not be encoded, or, I'm not familiar with all of them, obviously, or even any of them. But if they are encoded, they certainly may not be using the codes that you identified. If they're not encoded, then someone, I think what you're suggesting, and maybe that's the next screen, is that, hey, these are the instruments that we feel do assess the things that are important in, our domains. And then here are the codes that we expect you to be able to use, but it's up to you to figure out how to take the outcome of this instrument and choose the right code. Or are you doing that, filling that gap?
No, it's kind of up to you, but not really if you're leveraging the wisdom of the IG. And Monique's on the call. Monique, take it away.
Yeah, so ideally, for every question that comes off a questionnaire, the observation that's generated from that as a question answer pair in our IG can at least get tagged at a high level as being in the utility and security domain, for example, at the observation category level, Rob. But then the value sets are also sort of identified by domain, like there will be a value set for utility and security diagnoses, for example. The actual, I'll use the word mapping loosely, but the actual mapping of a question answer pair to a potential, let's call it a fire condition or diagnosis. We've said over and over again that ideally the authors of the assessment instrument should be participants in agreeing that, this question answer pair or yes to this question signals food insecurity or how inadequate housing. And if that is the case, we've been talking about ideally having a fire structure map that would show, what for each answer to a question, a potential condition that could be generated, derived from that questionnaire as a unconfirmed condition. So there is a lot of thought going into this, but the actual links right now do not exist. I think Sarah has provided that resource, the SRN tool. There has been some attempt to sort of say for each question answer pair what an ideal ICD-10 code as we know it would be, and a potential SNOMED code or more than one potential SNOMED code.
So let me spit back what I think you said. And I haven't had time to go. This all just happened so quickly with regards to me getting involved. So I'm not involved and I'm not up to speed yet. But so I haven't looked through the current IG. But what you just described makes sense in that the IG is and maybe it doesn't have structural maps yet, but the idea that there's, for example, more than one observation that might lead you to decide the patient has, or the individual has food insecurity. And so that would be a structure map in fire world if you've got all this represented in fire, which is great. What I'm asking about this, what you're displaying is in order for these tools to truly be, I think, aligned with the IG, right?
Mm-hmm.
I don't want to say that it doesn't make sense for you guys to certify them or whatever the word, that may not be the right word, probably isn't. But to say that they're instruments that seem to be doing the right thing is to map them, right? Kind of. So now you're saying, oh, okay, here's this it's an unvalidated, it's got, I guess, face validity IG that you've created with regards to how to determine, food insecurity. And now, but then you have these instruments that are validated, that some of them speak to food insecurity, or at least they, potentially. And so you want to, kind of like lay it on top and link the two together. Otherwise, no one, either gravity has to create its own instrument, or or you don't
Sorry, I couldn't find the raise hand. Sorry, Sarah. But yes, the way we identify the screening instrument is by identifying the specific domain related question in that instrument. So when we are referencing to all these instruments here, these instruments have utility insecurity specific questions in it. And that's why we are referencing it here. And from these instruments, oftentimes the instrument used in social care domain is a compound instrument where you will have food insecurity, housing insecurity, transportation insecurity. But we, for example, in prepare, there would be multiple domains covered. But when it comes to utility insecurity, we only take utility insecurity related codes from prepare and build our value set for utility insecurity screening questions. So all these screeners that we identify, so the way it workflow goes is that first identify all the screeners, which are specific to utility and security. Then based on those screening question answers, identify what can be the related diagnosis. Then identify, so the diagnosis are the question terms. So if food insecurity is a diagnosis, what can be an ultimate goal, which is food security? And then to achieve that goal, what all interventions are you going to perform? And there is an intervention framework. But to answer your question in a nutshell, all the screeners, when we identify for a given social care domain, they specifically related to the questions for that domain.
But they do not yet have the capacity to link that question to a potential directly through a map, other than the tool that Sarah just put a link to in the chat. That
and there's reasons why we wouldn't necessarily want to do
that. Yes. So we're not hardwiring, but you know, the idea of having a structure map that might give the suggested code, and then you know, a caregiver could, or a care provider could confirm on discussion with the patient that that code is correct. That kind of guidance would help improve consistency in reporting out of these screening instruments.
And we have a couple of examples in the IG and are crafting more. And then, but Rob, just know the logic of that is the intention of all of our build, right? That we select screening questions that can logically predict necessary diagnoses, either in ICD-10 or SNOMED CT, with domain-aligned goals and domain-aligned interventions. So it's a tidy little pathway.
So would you say that the desire with regards to structure maps, for example, you kind of, in your IG, you'd say, here's an example of how structure map might actually work. But you wouldn't be saying, this is the structure map everybody should use, because that's not validated. And instead, what you're providing with the IG is kind of trying to influence these guys who are building these screening instruments to, one, align the vocabulary that, well, actually, I guess what I'm saying is that you're encouraging them to republish or publish an updated version that uses FHIR and aligns with your IG. Would that be a correct statement?
Well,
That's how your IG could be used, is to get screeners to provide a FHIR version of their screening instrument that uses the codes that you've got in your value sets where it fits,
Yes.
specific codes, and then use, again, a structure map, presumably, as a way of being able to link the questions to the outcomes that presumably are in the structure map.
That's a dream of ours for sure. Yeah.
Yeah, and in a perfect world, you know, we're dealing with legacy assessment tools, but in a perfect world as they're developed, you know, the authors or participants would help, you know, sort of vet the structure map, so to speak. And, you know, we do have like a prepare structure map in our IG that sort of gives, you know, suggested unconfirmed conditions for each question. But yes, in a ideal world, there might be a vetted structure map, you know, that everyone agreed to.
And we can imagine a future where, at least, again, the ones that Gravity selects to build into LOINC are the ones that are most widely disseminated or best in class. So even if we just wanted to focus on those ones, right, that would be a significant step forward for the ecosystem.
And when you say the ones that you guys are identifying and want to put in LOINC, i.e. they're not in LOINC now.
Correct.
That would mean that means those are, you know, because obviously there are some instruments that are in LOINC.
We have a table for that.
So you'd be picking ones that are already there, but for ones that you're saying you might submit to LOINC or some other code system. Remember, there's, you know, the SNOMED stuff that's in there and blah, blah, blah.
So,
And you know, those are ones that have not been submitted, but you would be, again, you know, hopefully you're reaching out to these guys that are building these instruments and saying, hey, look, we're layering all this stuff on top of your thing. Please put it into what, you know, an updated version. Or you guys are planning on publishing the you know, that map. I mean, I don't know another word to use, but right. So you say, for this screening instrument, here are the codes that for the questions they ask. Here are the codes, so that those of you who implement the screening instrument, you can do this and now you're aligned with what this IG is proposing. Are you going to go that far?
Well, we could. I'm just going to ask for the sake of the agenda.
Yeah,
Because,
go ahead.
yeah.
Sorry.
No. We have we invite you to come to a terminology meeting to walk through that, only because I don't want to completely hijack the rest of the agenda, and it's so exciting what you're talking about. But Hamali is now unfolding, Hamali well, of course, right? All of the different resources we have to support that future, right? And I even have a strategy of where we'd want to start with that.
No, I'm done. I just thought was very helpful to kind of get a sense of where you guys are going. So thanks.
We hope you're not done, Rob.
Oh, I mean, today.
All right. All right. Okay. So I think we're done with screening assessments and we can move on. And then Sarah Bahal has also dropped into the chat our list of all of our value sets for every single domain. And those drill down very recently this summer. We went not just to the panel, because Hamali was talking about comprehensive instruments and the questions within them. So this summer, we also published value sets of every single appropriate question and appropriate answer to facilitate exactly that future you were talking about. So this is the additional Acorn screening tool. Again, how often do you have trouble paying for your utilities, electric, gas, oil, water, or phone? You can see this is one that includes phone and utility, so why we're holding space for it. And this is one that also represents the trouble paying for element as opposed to not actually having. Even the second question is a threatened to shut off as opposed to not necessarily completely shut off. So you can see the material hardship terms that we already have for utility insecurity are definitely going to need refinement in the spring in order to capture the full breadth of the domain. Next slide. All right, that was the end of utility insecurity. So the mission is to just leverage terms we've already built for past domains in order to give implementation guidance to people who want to make sure they're aligning with gravity and standard data elements as they work on reporting for IQR, and then full utility and security build in the spring that will fill in all those gaps and assess some of the problems. Now moving into interpersonal safety process. Again, this is just process, no terms whatsoever. And we'll talk about why. So again, the IQR measure focuses on the domain of interpersonal safety because it's based on the broad interpersonal safety approach of the Accountable Health Communities Health-Related Social Needs Instrument, which includes its interpersonal safety questions are an intimate partner violence screener that was adapted to be able to be used for all ages and all types of interpersonal safety. So when Gravity assessed this domain, our SMEs in elder abuse and intimate partner violence basically asked/demanded that we subdivide interpersonal safety into known subdomains because that's where validity happens. All true psychometric analysis and measure development happens at the level of the subdomains. There are specific instruments and diagnoses and approaches and interventions for interpersonal violence, specific instruments and approaches for elder abuse, etc. And so they asked us, and again, these are some brilliant experts across the national ecosystem to focus on those two, which meant that we didn't address interpersonal safety as a bucket, as a fluffy domain. It's not a thing. It's a set of smaller measurable things. So we addressed elder abuse and intimate partner violence, but that means implementers are having a hard time understanding guidance to support IQR. And I can say, as someone who's leading revision of IQR and fully dove into IQR in order to help with this work, I can understand why, because it's kind of confusing. So we're going to offer guidance to assist implementers, and we have some updates there. Next slide. So one of the things we just want to note too, that in addition to IQR, interpersonal safety in that highest level is also one of the domains within the NCQA Health Equity Accreditation Plus. And so we reached out to NCQA to coordinate on that as well. There are some interesting differences. There's some things that are very much similar, but NCQA Health Equity Plus is an all ages initiative. IQR is an 18 and plus initiative. We know from our, hi, Samantha. Hello. You're muted, I think.
Didn't mean to interrupt your beautiful flow. I wanted to go back to some of the history you just shared, but do you want to finish your thought first?
No, you can go back.
Okay. All right. Well, listen, do you mind going back to the previous slide?
Yeah, no problem. It's better to go back with everybody together. Yes.
Thank you so much.
Yeah.
I really appreciate this historical context and that we need to sort of operate within the confines of the categorizations that have been determined to date.
Mhm.
Since on this slide, I see a reference to elder abuse and intimate partner violence. And I think in the next slide, Sarah, there's a kind of placeholder for child abuse and neglect.
Yes. 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 Yep.
And again, this is just honoring the complexity of violence and safety. Is there a similar placeholder somewhere for people living with disabilities? Because, okay, good. I just wanted to make sure that is still in the sort of taxonomy family that is being considered. Okay.
Yeah. So we have toxic stress and measures of trauma, which would have addressed specifically, that's the way violence screening happens in the pediatric space, right? It's the childhood trauma scale, or it's the ACEs screener that's used extensively in many different states as a screening instrument. Yes, Rob, it's posted on the Confluence.
Sarah, I may be thinking of something different. Most states, I'm not ready to say. I'm sorry, but you weren't done.
Yeah, I'm not done. I'm so sorry.
I'm sorry. Okay.
Yeah. And when we did elder abuse, we took very great pains to consider whether we wanted to address the reporting requirements for vulnerable individuals who are non-elders, which are, because we know full well the reporting requirements such as mandated reporting and APS fall into play in vulnerable situations. And so we held space for that as well, right? Because it was one of those, it's super important, we have to do it. And so one of the things this work is helping us do is understand full guidance for interpersonal safety really needs to look into that, which is very similar to elder abuse because it involves a perpetrator element I will show you shortly.
Wonderful.
And also child abuse and trauma and toxic stress. So yes.
You've addressed my question beautifully. Thank you so much. Okay.
Go team. All right. So because Samantha, she teed us up because she does that because she's so smart. So right now, for the purposes of our guidance, because we only addressed adult types of violence, we're not addressing child abuse in our recommendations for IQR. IQR is also only an adult measure. And so right now we're staying in the lane of adult approaches for multiple reasons. And again, there's lots of to be determined, which are gravity future work. You'll see it on the algorithm. All right, go team. Next slide. Whew. Okay, so one of the reasons why it's a little complex and one of the reasons why I can understand our implementers asking us to help is when you look in the IQR screening for social drivers of health measure, instruments are self-selected and their example instruments are a little complex because they include instruments that have only interpersonal safety questions, and they include instruments that have both interpersonal safety and intimate partner violence questions. And the same thing happens with NCQA. So they reference the same 3 general interpersonal safety questions. And again, the AAFP instrument just uses the AHC, health-related social needs questions, so they're like the same. But then they also point to all of the interpersonal violence questions as well. So implementation might be a little tricky because there's not a ton of guidance. And the reason why the siren table is important is because the siren table also includes all of the validated interpersonal violence questions that are unique instruments out there, like the HARC tool or the HITS tool. And we have those in our sets as well for intimate partner violence. So next slide. So when it comes to supporting implementation, the way, again, we have to stay in our lane. We have to stay within what we've done, right? And the evidence we've amassed. So we know very clearly that all interpersonal safety screening, regardless of the subtype, should start with the cues model, which we'll go through very shortly. And then we can generally suggest a secondary pathway. So if you prep screening with the cues model and you follow with a set of questions, we at least can say, these questions lead you to this domain and a need to assess and our value sets, right? And again, there's going to be lots of others to be determined, holding space for Samantha, the subtypes that Samantha was mentioning, and then anything that falls outside of the bucket completely. Next slide. So this is the cues model, again, instituted and brought to bear by our intimate partner violence subject matter experts, accepted universally by all of the experts we worked with, and there were 10 experts in intimate partner violence and elder abuse that we worked with over the course of our build there. Because the principles of screening for interpersonal safety and intimate partner violence and elder abuse are very, very clear, evidentiary. Like, you have to prep with a sense of confidentiality. You have to offer universal education, which is regardless of what you say, I'm going to give you resources. They might come in handy. And that means the person who might not feel safe enough to disclose in that moment still has the resources that they need in order to be safe. And then you have to support them in the sense of a positive. You have to do warm referrals. You have to do health promotion and like care planning. And this looks like what we know to be in Gravity, right? So it's best practice with a lot of principles woven in, right? A lot of patient-centered, social justice-minded principles and worked in here. So the good thing is we have an update. So the amazing terminology team, Asha's no longer with us, but Sarah Bahal and Amanda Sagewall have been leading the publishing of this very important instrument and approach into LOINC. And we know after we had some lovely meetings with registries this summer, and it's reviewed and in process for publishing. So we'll be published in LOINC very, very soon. Super exciting. So as soon as that comes into the ecosystem, we will let everybody know. And then next slide. I think, Jonathan, what did you just put into, I can't open it right now, but what did you put into the chat?
I just put in a screening tool for interpersonal violence from the, hold on a second, I got it pulled up here. From PubMed Central, the National Library of Medicine.
Okay, we will see if it's in our sets. My guess is it probably. I will gather it.
I would not be shocked if it was.
I know. Okay, so these are this is the process we're working on to support implementers who are working in the interpersonal safety space with how to navigate to Gravity standards, right? So the way it would work is everybody starts with the cues model on the left. Again, there's no new terminology here. This is just best practice and process, right? Everybody starts with the cues approach on the left. You then have your interpersonal safety screening, right? Your AHC tool, the one item, WellRx question, the questions that are in the Everyone tool, or the question on the Prepare Screener, or any other question that applies. The question that Jonathan just put in there, right? Again, any general question is not in our Gravity value sets because our value sets are specific to intimate partner violence and elder abuse by design because they are unique. And that was the decision of our SMEs. And if it's negative, you rescreen at the next interval. If it's positive, the best way to navigate to Gravity from interpersonal safety is to ask questions about the perpetrator. So if you ask a question about whether or not the perpetrator was an intimate partner, and the answer is yes, you then enter the realm of intimate partner violence assessment and standards, right? If you ask the questions about whether or not the perpetrator was a trusted caregiver, if you remember from elder abuse, that's a really critical must-have. And the answer is a yes. And then you ask questions on age of patient, and you and then the answer is 60 to 65 state dependent. It's annoying, and Samantha probably knows this. Like the rules for determining elder abuse depend on what state you're in. And then it's a yes. Then you enter our elder abuse assessment and standards. And if it's a no, this is where, Samantha, further guidance to be determined is that bubble we talked about, right? adult interpersonal safety screening, if you get here, right, then that's where the trusted caregiver, dependent, vulnerable adult situation could apply. And then there's, of course, other types of violence that aren't here either. And so that's the middle other further guidance to be determined. Does this make sense? A little flow chart to help our friends. No new terminology, just how to get to the standards. And the moment you hit intimate partner violence assessment and standards, you have the robust capacity of our value sets. You have our diagnoses value sets, you have our goals value sets, you have our intervention value sets. All available in the Confluence or VSAC. Okay. I think we're good. We're gonna mull on this for a little bit. Again, it seems pretty solid, but we can pick it apart. And then,
Sarah,
yes?
Sarah, this is a question from Mars. Once it is determined that there is intimate partner violence or elder abuse or whatever may come with further guidance, there has to be communication with government authorities in
Correct.
some situations.
Yeah.
Does that belong here? And are any government authorities going to be understanding our codes?
So I can
How's that going to work?
So we build referral to adult protective services within our elder abuse assessment standards, because that's where it by law applies, right? And I can tell you that the CDC's top experts in surveillance and APS were on our SME list. They were brilliant people who work with the CDC and the federal government and the Office of Minority Health and Administration of Community Living on these exact topics. And they were super excited that these codes were developed, both from a reporting and surveillance and standardized perspective. So that was part of our design.
That sounds terrific. I hope other people on the call have the same question and are now reassured. Thank you.
Okay. Any other questions? My old dog on the couch. All right. I know we're at the top of the hour, but we have one last topic, which is really philosophical. So brace yourself. Okay, next slide. This is a unique terminology build, updates, and action steps. Okay, next slide. That was so long, I don't know if I can read it. This is a very busy slide. I'm so sorry. It was crafted very early this morning. Really what's happening is a few things have come to bear where we're asking to kind of, or suggesting that we pause on some of our specific IC10CM submissions. And pause does not mean don't do it for digital inequity, because of a bunch of factors and because of interconnectivity with utility and security in the spring. And we're going to run through that. So the preface is that Gravity has learned a lot, and we've been around for 4.5 years now. And we've learned a lot over the course of the 4.5 years, and some of it's by learning, by doing things and then realizing it didn't work, right? In general, it's important to know at the highest level that the terminologies of ICD and SNOMED CT have different purposes, right? ICD at heart is a classification system, and SNOMED CT is really designed to be a clinical language crafted to support patient care. So SNOMED CT is built to offer the granularity and specificity and, easy language that ICD may not have, right? And they work like they're sisters. They do different jobs and they do each of their jobs very well. So in analyzing our digital inequity IC10CM submission, which will still be submitted in December, just maybe a little bit different, we assessed a few factors that led us to consider holding on some of the IC10CM levels of granularity at this time. And that doesn't mean not building them. It just means waiting for the following reasons, right? We'll still have likely parent codes in ICD and still have all the granularity in SNOMED CT. We're just wondering on whether it's reasonable to hold for a second because of the following questions. We really need to assess where phone access belongs, right? Is it in or out of utilities? If it's out of utilities, Does it get clustered with internet as some kind of classification with an ICD? Until we address utilities, we don't know the answer to that question. And so we want to hold. Again, utilities is just happening in the spring, so it's not a long wait. It's just like we really clearly define digital access with very clear intent. Most assessments of utilities do not include phone, and so then we're left with this little thing in the middle and trying to figure out what to do with it. Hi, Rob.
Hey, so I don't know how much you want to talk about this now, the questions that you're asking, but I'm sure Monique might have some opinions, but so I mean, I would suggest that the use of what this group would be suggesting for additions to ICD would be that, I would hope that we would maintain the idea of ICD as a billing code system. It's not a clinical documentation code system. And so where it comes into play, and you need payers to help you with this, and they may not have really even figured it out, is are there different payment consequences with regards to these different nuances in terms of the insecurities? I'd suspect not.
Well, yeah, so
right?
I can tell you, so the great thing is that our payers are very involved in this discussion. Our transportation, like the levels of granularity we built within homelessness was because of the different risk involved in different subtypes of homelessness and wanting it for value-based reporting. And then that's partly why CMS included the different strata of homelessness.
That's a reflection on the fact that you got a hammer, everything's a nail. So I don't know that I want to have this conversation right now, but the point is that if we acknowledge that there's more than one code system in play, then we ought to actually act like we acknowledge that.
And I think this is
not put all the details into ICD or CPT and use SNOMED instead.
Yes. Yes.
Right. So I would suspect there'd be very few ICD codes.
There are substantially fewer ICD codes than SNOMED CT codes by precedent. Absolutely. No question.
Well, you just mentioned that there was an interest in using ICD codes to do risk assessment, which is not what ICD should be doing. I understand that risk actually is a part of what ICD is it's a mortality assessment tool. But anyway, I don't think we want to have this conversation right now, but the fact that we're putting a lot of effort into identifying the nuances and giving SNOMED CT codes, that kind of information is what we need to get the payers to really understand.
Correct. Right. And sorry. And I just want to note for one thing though, because like there is risk in ICD, like the difference between diabetes uncomplicated and diabetes with hyperglycemia, for example, that's a risk statement, right? That's conveyed in ICD-10-CM for value-based understanding and hierarchical condition coding. So there is like some element of risk in there.
Well, I get it. That doesn't mean I agree with it. So anyway, like I said, we could have that conversation later. And my opinion is just my opinion. But one of the nice things about the work that's happening here and elsewhere is this, acknowledgement that the details of clinical care can be represented in SNOMED and that we don't have to also put them into a billing system.
Yeah,
but what it does mean is that those organizations that want to do, risk assessment may actually have to capture clinical information using SNOMED instead of putting that into ICD. That's a change in the way that people think.
Yeah, that sounds like an even deeper philosophical conversation than we were planning. But I think what you're saying is so timely and aligned with what we're presenting that it's like you set it up, right? Because we're literally saying the same thing. Like even if we wanted granular, even if we want granular, and Sue Bowman from AHIMA is on here, and Tammy Love from the American Hospital Association, and our lovely Linda Hyde, and I don't know if Danae, AHA and AHIMA are all around. just know you're in good company.
Yeah, no,
Yeah.
I get it. And I'm not saying that, the work that was done or the approach taken to, expect that providers represent information sufficiently well that all that you need to look at is ICD in order to do risk-based pricing in your models. That's the way it's been forever. But I'm suggesting that a lot of the work that you're doing, and it's not just in this project, is that the kind of nuances that are important even for, insurance work should be based on SNOMED information instead of trying to pack it all into IC. That's what I'm saying.
Yes, and SNOMED does a lovely job of it, which is why we really feel comfortable saying we don't want to build a lot of granularity in ICD right now. So that's why what you're saying is so aligned. It's like perfectly.
Yeah, good.
So yeah, so what these are all the reasons why we're walking back on some of the ICD suggestions we had at the end of digital inequity, pushing to building them in SNOMED, because that's what SNOMED does really well, and just assessing need in ICD as we go forward with a couple other factors, right? And so there's figuring out where phone access belongs. There's figuring out how to build in those community level terms that we identified, the digital access not available in community, into the Z58 route, which is where they would go. We also need to consider that ICD-11 is out there, and we don't want to offer tons of complexity that's just going to get rolled up when ICD-10-11 comes to bear. And we also recognize that things like the CDC inadequate housing utilities was a race to create an ICD-10-CM code that actually creates some complexities because it's not actually aligned with the highest level concept that we could have made that would have been more inclusive. So for all these reasons, we have a suggestion on pause, and you'll see the pause is in italics, and the pause aligns directly with what Rob was saying. So minimal build, right? So right now, we were going to go forward with a submission for a new digital access. Well, we knew we wanted, I'm going to phrase it this way. We knew we wanted a term to state when you didn't have digital access because it was not available in the community, knowing that there are, especially seriously rural settings, this is partly sometimes the reason why my patients don't have digital access. Initially, we were like, let's build the mirroring ICD-10-CM code, not just the code in SNOMED CT. Now we're walking back on that a little bit. In italics, we're going to say, let's think on it, because these are the terms that already exist out there. The Z58.81 we built ourselves already has an ability to obtain internet service due to unavailability in geographic area as an inclusion term, and could easily be used for the most severe element of this condition while we think, right? So this is a good, we're just going to sit on it and think, go forward with building SNOMED CT, our beautiful definition available for use. But again, our suggestion is to pause, and I'm going to run through all of these again, because it's because of phone, it's because of Z58 itself, it's because of really trying to be cautious because of things that have happened before, and just wanting to take a little bit more time, because remember, we have to submit in December, so it's just a month away for March. And then next slide, and then on here, if Tammy, Sue, Linda want to say anything brilliant, let me please pipe in. Next slide. And then the way that would work is, again, all the granularity that we desired for clinical documenting, for building care plans, for taking care of people, will be suggested for build in SNOMED CT with all of the definitions we worked on, but hold on a specific ICD-10-CM code for person level and adequate digital access, and just use the other problems right now while we sort it out. And again, if the ecosystem hears this and they're like, oh my gosh, we need it, we can cross that bridge. But even finishing utility insecurity in the spring seems to make a lot of sense initially before we build more granular terms. And again, if your comment on this suggestion is absolutely not, go forward. then we hear you, but this is what we're thinking about, given the fact that utility insecurity is coming and everything that we mentioned before. Next slide. And then this is the same concept carried out with the other elements there. So next slide. Again, everything staying in SNOMED, just pausing on IC10CM. Next slide. And then what we're suggesting with digital literacy is, for right now, proceeding with the big parent and then building all the granularity we desire in SNOMED CT for exactly the reasons we've been discussing, right? So we recognize the difference between general digital literacy and missing those base digital literacy skills. Right now, assessing everything, we're again trying to figure out everything that's going on with utilities, suggesting submitting in December that highest level term, submitting all of our SNOMED CT terms, but pausing on the more granular stuff for now. And then it looks like Deneen, looks like Sue and Deneen Harper having a comment in the chat. Next slide. And again, that same thing where that meta problem with digital literacy would then apply to all of the different subtypes and SNOMED CT elements that you all determined. Next slide. And that's it. Okay, now we can go back. Okay. So that was the philosophical bomb, and then very timely, Rob brought it even to a farther conclusion. We might, if there's no early comments on this, we could let it sit and simmer, and then we can come back next week. But again, it's really trying to be thoughtful and careful, and considering the domains we have upcoming, that we're thinking about this approach.
And Sarah, while that discussion was ongoing, about ICD and its purpose, that's when Sue put the comment in that it is used for things other than billing. I'd like to give her a chance to, just because it's part of this discussion, to.
Yes, please. Sue, do you want to chime in, friend?
Sure. It is obviously used extensively for payment purposes, but it's also used for a lot of data analysis purposes. It is starting to be used quite extensively for not just social determinants, but other sorts of risk factors and personal history and genetic issues and so forth. But I completely agree that it is not a terminology and is not intended to be a terminology, and that some of the more detailed granularity should be in SNOMED, perhaps, and not in ICD-10. And also, Sarah, as you very well explained, we also have to stay aligned with some of the higher level concepts and 3-category terminology that is in ICD, because that ties back to the World Health Organization's version that we could not change. And of course, now the WHO has developed ICD-11, and we're all looking at how those codes are structured moving forward, and we'll have to follow that format and what they've done there as well.
And the great thing is we have SNOMED to be what SNOMED is. Like all the beautiful things that we want to say, the storytelling that I do with patients, the concern on the problem list, problem with basic digital literacy skills, that will be able to stay on my patient's problem list, and I will work on it over time. It can be part of my care plan. It can be everything I need it to be. Monique?
Yeah, I wanted to get one feedback on this approach from Rob, which is that, if we have, and we have had, and we're going forward, we'll continue to have a much more granular approach to the SNOMED code. So they'll be much more specific. And in our IG, when we create a condition out of one of these questions, sometimes there's an ICD code that has an exact match, like food insecurity has an exact match in SNOMED. And sometimes there will be an ICD code that has a much more granular SNOMED code that have come out of a question from a questionnaire. So that question on a questionnaire leads to a sort of a non-granular ICD code and a more granular SNOMED code. And we have in our profile the ability to create one condition using both of those codes, Rob, although one is much more generic than the other. You don't see an issue with that as far as fire, do you?
To the extent I understood what you're saying, no.
Okay, okay.
Any other comments on this? Again, it's a philosophical statement and just again, knowing we can do everything we want to do in SNOMED. Well, not everything. Again, it still has to go through authoring in SNOMED, and there's still a lot. I mean, I have to just give a nod to the brilliant Kathy Richardson and John Snyder, who walk with us in all of our submissions in SNOMED CT so brilliantly. But are we feeling okay with this shift? Thank you, friends. And I want to thank again, I called them out, but we would not be able to do anything we do in ICD without the wisdom of our friends Sue Bowman, Tammy Love, Janine Harper, Linda Hyde, and Kathy Gianangelo. They are brilliant people who help us work through all of these complexities and did not suggest this per se at all. They just were wise, and then we thought about their wisdom. So thank you, friends. We really appreciate you. You're the best. All right, so your homework is to review the master list. It's going to be published tomorrow in the afternoon. Catch up. I mean, everything that we've said and what we've dropped a few links in here is available on the Confluence. The recording will be there as well. Reflect on the process for interpersonal safety. It seems pretty good. And then we will see you again at the OK Corral in 2 weeks' time. Thank you, Tammy. Bye, friends.
Thank you.